Good morning and welcome to day 3 of the escaide 2020 conference. We're now starting with our first plenary session on COVID-19, and our hosts for this session are Magdalena Rosińska and Mike Catchpole. I'm going to leave it up to them to introduce you to the themes. Magdalena, over to you.
Thank you, and good morning everybody, and welcome to the keynote session of escaide on COVID-19. So the topic of this session, of course, doesn't come as a surprise to us. We were all facing the crisis throughout this year, and as the evidence increases, we all face many questions, and many of them are quite easy to ask, but quite difficult to answer. So with this session, we will have the opportunity to ask these questions to our distinguished speakers. And this will be about epidemiology and public health response as relating to China, Europe, and globally, as well as to some perspectives for the future. So let me first introduce how the session will be organized. We will go through 3 questions, and all 3 of them will be asked to our 3 panelists. These questions relate to the current state of the pandemic and its main drivers, to what we already learned about the epidemic, and finally, outlooks to 2021 and the key messages for public health regarding the pandemic. So, after each question is asked to all 3 panelists, there will be a short discussion around the topic. So, in case you want to intervene, please leave your suggestions and comments or questions on the chat box, so we can take them, summarize them, and take them to the panelists to comment. After the 3 questions and the discussion is over, we have the time for panel discussion. And this panel discussion is aiming to discuss a little bit the challenges in communication of the scientific evidence to the public, and the challenges to balance between the evidence and the considerations of the political and socio-economical aspects. So we put together 4 topics for this panel discussion, one of them being restrictions to the cross-border movement. Second one, effectiveness of different interventions. Third one, the priorities for vaccination campaigns, and also finally, if there is a danger for response fatigue and how do we deal with that. So these are the 4 suggested topics, but if you want to put forward some other comments or questions, please feel free to do this, and we'll try to accommodate this in the panel discussion. So, without the further delay, I would like to introduce the first question, and the first question is, what is the current shape of the epidemic, and more importantly, what are the main drivers of the epidemic? So, with this, I will pass to Mike to introduce our speakers.
Thank you very much, Magdalena, and we have 3 speakers who've been absolutely at the forefront of the COVID response. And the first of these speakers is Fu Gao, who is the director of China CDC. George has an illustrious background. You can read it in detail on the escaide website. I think I'll keep the time available for George to tell us about his experiences in China, and then particularly to start with what has been the epidemiology in China and what does he see have been the main drivers. So George, if I could pass it over to you now to answer that first question.
Hi everyone, good morning or good afternoon, wherever you are. It's a great pleasure for me to be here. Especially this is the first session about the shape of the pandemic and the main driver of the pandemic. I'd like to start with share with you some slides. Can I have my first slide, please? Where is it? Here? Oh, okay, I found it. Yeah. So, where is it? No? It's very slow. Anyway, you know, when we first notified we have some pneumonia with unknown etiology, PUE, in the last day last year. So we immediately got everybody together. We sent a team working in Wuhan. Of course, you know, the virus was first discovered in Wuhan. You know, this typical coronavirus. This picture taken on the 7th of January. You know, immediately we did all the sequencing and shared all these clear coronavirus. Of course, so after that, you know, the key question from the very beginning is first, what kind of virus we have? Of course, it's a, where's my, how can I control next slide? It's very slow, I'm sorry, it's very slow. But you know, first we notified what it looks like, what it is. First, virus, how and what looks like. This is the EM picture for you. And then it's a sequence. So what kind of virus it is? What's the relationship of this particular virus with other coronavirus, including MERS, SARS? So typically it's a beta coronavirus. I'm sorry, my slide very slow. And the third question would be, so what is the incubation period? You know, yeah, what is the incubation period? And the fourth question, what is the transmission route? So we quickly, within a few days, a week, we answered all these questions. I'm sorry, my slide very slow, but I hope you already see, you know, where we are now. So China very quickly got a lockdown strategy for Wuhan. As you know, the virus was first identified in Wuhan. The cases with PUE also found in Wuhan. But now half a year, now almost 1 year. So we know the virus, origin of the virus, we have no idea where it comes. From the very beginning, learned from the MERS, SARS, and any other emerging viruses. We thought there might be a, I'm sorry, it's very slow. Yeah, very, very slow. We know, you know, there's a lot of questions there with this lockdown. So we got the disease control, you know, very quickly in China. So I'm sorry, but I showed you here the 4 key questions we quickly answered. Those 4 questions. Let me show you. I'm sorry, but show you again. Yeah, can you help me? Yeah, virus, sequence, test, vaccine, incubation, and transmission. I mentioned that already. And now I come to what we have done for lockdown. You know, the first 100 days in China until April 8th, we claimed in Wuhan, everything's clean or clear. So after that, we have a lot of imported cases in China. And then after that, you know, we have so many diseases for that, and we adjusted our technical documents, protocols, you know, from based on the timelines, you know, whenever we found, you know, what's the new science-based evidence we got. In general, in China, we already have 7 waves in China. Let me show you why I've said that. The first wave is in Wuhan. So after that, we have imported cases from Russia. Here, second wave, in northeastern provinces. And then we had in Beijing, everybody knows that, Beijing, Xinfadi. And then we have 4th and 5th in Dalian, Urumqi, in Xinjiang Autonomous Region. Then we have something in Qingdao. And then we had the 7th wave in Xinjiang, Kashi. Of course, at the moment, we have many sporadic cases in China, in several provinces, at least in 4. Inner Mongolia, Tianjin, Shanghai, Anhui. I think, because of the pandemic in the whole world, we might have some more. So in general, this is where we are. And I know it's very hard for everybody. We still don't know where we are going to, but at least I know in China, we might have some more sporadic cases. I was asked, is this pandemic inevitable? So obviously, when you are talking about a virus and human interactions and relations, the conclusion at the moment for me, first, the origin of the virus is unknown. That means we might have another new novel coronavirus, because we don't know the novel coronavirus already adapted to human being very well. And the second, even though we had this one, but I don't think we are ready for the next one. So we have to get ready to get the whole core facility, everything ready there. I think I will stop here. I'll be ready for discussion. Thank you. I think I'm sorry for very slow slide here. Thank you.
Thank you. Thank you very much. I am not sure what happens with the slides. Hopefully they will move more fast for our next speaker. And I would like to now pass the floor to Andrea. Dr. Andrea Ammon is the director of the ECDC, and she will take us through the perspective from the European viewpoint. Andrea, the floor is yours.
Yeah, thank you very much, Magdalena. And I would like to have my first slide. That's a few further. Yes, one more, please. There is no button for taking control. Please, yes, that's the slide. Thank you very much. So on the left graph, you see basically how the pandemic unfolded in the EU. We had the first cases in January, and then the first wave really hit end of February and March to 9th of April, where it peaked and then went down due, that's our assumption, the massive measures that countries have taken. You see then quite staying at low levels until probably August, and then a sharp increase. And people ask what has happened here. Now, in order to really understand what has happened, you have to look at the right curve. That basically indicates in the dark green line the tests per 100,000 population. And you can see that basically from March to now November, there was a steady, actually steep increase in tests. Now, what you also can see is that this increase in tests during summer did not immediately lead to an increase in cases. This is why it's good to look at the second curve on the right side, the dotted line, which is the percentage positive of the tests done. And there you see that coinciding with the increase of cases, the positivity rate also increased. So this positivity rate is a very good marker to indicate that there is ongoing transmission, and from that moment onward, the increase in cases couldn't be explained in the with the increase in testing. What you also can see is that when you look at the peak in spring and the level of or the number of tests that have been done per 100,000, that this peak probably would have been a lot higher if the same amount of testing would have been in place. Next one, please. Yeah. So now the other interesting factor is the age curves. You see here for the spring peak that the majority of cases was actually in the over 80-year-olds, and also the next age group 65 to 79 was quite represented. Now the peak in the second wave started with the group 14 to 24-year-old, and they are still making the majority of cases. So that is also quite a difference between the two waves. Now, what you can see though, when you follow the 80-year-old line, is that now we see another steep increase. Signaling that the transmission has gone within the community between the age groups. And when you look at this peak in the level of the peak in April and where we are now, we might see a lot more deaths than we are seeing right now still to come, despite the fact that we have now better possibilities to treat. Now, the last thing that I wanted to indicate is that the picture within the countries between the countries looks now fairly homogeneous, except for a few of our northern countries. But within the countries, there are still differences. Still, the picture indicates the geographical spread now is much more widely than it was in spring, so that it might also not longer to control the pandemic. And the fact why it actually went on is measures were released and people were very happy that they could see each other again, and probably a bit too enthusiastic. But I think we are coming back to this. Thank you.
So thank you very much, Andrea. So we've heard about the evolution, the early evolution of the pandemic in China and the evolution in the EU. But of course, this is a pandemic. It has a global scope. And so I'm really, really pleased that we have with us Maria van Kerkhove, who's technical lead in the World Health Organization's Health Emergency Program in the High Threat Pathogens Unit. And Maria's probably had more screen time than most of us could ever imagine this year in terms of presentations. And so I'm afraid I'm asking Maria again to give us an update looking at the pandemic's development from a global perspective. So Maria, I can hand over to you now.
Thank you so much, and thanks for being on this wonderful panel with all of you today. So good morning, good afternoon. Yes, I have had way more screen time than I think anyone should have in a pandemic. And just to preface this by saying I never, ever, ever thought I would be a forward-facing person in a situation like this. But nonetheless, I am grateful and honored to be part of that team, to be part of this team that is dealing with the pandemic like all of you. So I just have a couple slides here to go over the global situation and where we're currently at. So this is an overview. This slide here is showing you the global epicurve, and the colors that you see here are the WHO regions, our WHO, 6 WHO regions. And what you could see, and you heard from George, the early days of the initial cases of the cluster of pneumonia of unknown etiology, which we were made aware of on the 31st of December. And we immediately knew that there was something here, given that this is the middle of a flu season, and that the Chinese colleagues were able to capture a cluster of pneumonia of unknown etiology. We immediately activated our incident management team at the 3 levels of our organization, and this is in our headquarters here in Geneva, in our regional office in the Philippines, and also Western Pacific regional office, and our country office in Beijing. And through the gathering of information, release some information to our contact points and our IHR focal points on the 5th of January, giving a summary of what was happening and what we knew, and what the Chinese counterparts were doing in terms of better understanding the situation. And within 10 days of learning of the cluster, we had started to issue our first technical package of guidance. Now, this is what WHO does. We develop guidance and advice to our member states, to everyone everywhere. And the reason we were able to do this so quickly is because we had all these networks in place, and we had existing guidance developed for MERS coronavirus, and of course we had guidance developed for SARS coronavirus 17 years ago. But the 30th of January was when WHO issued and declared a public health emergency of international concern, which is the highest level of alert under international law. Describing the situation as a pandemic is not a level of alert under international law, it's a description. And you can see on there on March 11th when WHO first described it as a pandemic, although we had talking about the potential of it becoming a pandemic. And then you can see the unfortunate events that unfolded across the world. And to date, we have more than 59.4 million cases confirmed globally. I know this one says 59.2, but this is from yesterday. And we have more than 1.4 million deaths reported globally. Now, if you look at the situation across the world, it is quite different. We do a weekly summary every week, and then we do daily summaries every morning. But on Mondays, we look back at the previous 7 days. And in the past 7 days, this was as of the 22nd, there were 4 million cases reported in 1 week. So this is still growing exponentially in some parts of the world, but the distribution and the spread of this virus is not the same all over the world. Cumulatively, we've had, as I said, 59.4 cumulative cases and 1.4 million deaths, but there were 10,000, almost 10,000 deaths reported in the last 24 hours. This is really a stark and sad number that we are seeing. On the right-hand side here, you can see the countries with the highest number of reported cases in the last week, with the United States, India, and Brazil still quite high. But there are a number of cases across Europe that are really having large growth in cases, and not only cases, but hospitalizations and admissions to ICU, which is what we are really worried about. But if we break this down by our WHO region, you see very different patterns. As Andrea had pointed out, if you look at Europe, you can see the curve in the spring, but also in the autumn that we're having here. But it's very likely that that curve in the springtime wasn't actually fully captured because of the limitations of testing. So that peak in the spring was likely a lot higher than what we are actually seeing on this graph. And then across the world, the different regions are driven by different countries. Africa, for example, is largely driven by the outbreak in South Africa. In the Eastern Mediterranean region, this epicurve is really driven by Iran and Iraq at the moment. And so you do see different patterns. But essentially what we're seeing is that countries are facing different transmission situations. There are many countries that have avoided large outbreaks, and these are many island countries where they were able to quickly, or first of all, prevent cases from arriving on their shores, but then any cases that arrived were able to largely stamp it out. And we do see that countries that had experience with SARS in 2003, that had experience with MERS coronavirus, countries that have had experience with H5N1, countries across Africa that had a lot of experience with infectious diseases like Ebola, like monkeypox, like cholera. Many of these countries had the public health infrastructure in place, had the experience, had the trauma of really dealing with these types of infectious diseases, and knew immediately how serious this was, and really robustly and rapidly and strategically used the supplies that they had in hand to control COVID. We do see countries that have had major outbreaks but have brought them under control. China is a good example of this situation. We see many countries that have had major outbreaks in the spring, which are now seeing resurgence again. And we see a lot of countries across Europe, many countries across the Americas in this situation. And then we have countries that are just still in intense transmission. They've never brought COVID under control, and they're still seeing a growing intense transmission. So this leads me to what our strategy is. And WHO's strategy from the beginning has been and still remains to suppress transmission, to save lives, and to save livelihoods. So we outlined a global strategy on the 4th of February, 4 days after the public health emergency of international concern was declared, and outlined a comprehensive approach which takes all of these elements into place to try to control this virus, including mobilizing all sectors, because we knew immediately that this would be beyond health, and it's always beyond health anytime we have outbreaks like this, to mobilize all sectors and communities to make sure that they have a role, they know exactly what they need to do to prevent transmission through individual level measures like hand hygiene and respiratory etiquette, physical distancing, make sure that we had controlling the sporadic cases and clusters so that they didn't develop into community transmission by active case finding, isolation of cases, providing them with appropriate care, contact tracing and quarantine, making sure we suppress community transmission through context appropriate IPC measures, population level physical distancing. So these are some of the restricted movements that we've seen, and appropriate and proportionate restrictions on non-essential domestic and international travel, to reduce morbidity and mortality by having appropriate clinical care, making sure those that need it provide the care that we have. And we've seen incredible advancement in terms of therapeutics, although there will be more that hopefully will be coming online, and really to develop and rapidly develop safe and effective vaccines and therapeutics that can be delivered at scale, and making sure that they are available for all. So that's what we have outlined. And this is the approach that many countries have used. They've tailored it to fit their context, their population, the way that they are governed, the cultures and values that are in the populations, and really to make sure that we have an enabled and an empowered and an informed community. So I will stop there. Back to you.
Thank you very much, Maria. So 3 fascinating insights, the way the epidemics developed. And I'd like just to ask a question to our 3 participants. It's quite striking, as Maria commented, the different shapes that we see in the different the different global regions. I just wondered, Maria, whether you feel that to any extent there is any evidence from these variations in any kind of seasonality effect in driving what we've seen with COVID.
Thanks, Mike, for the question. We don't see, a lot of people have asked this question. A lot of people are looking. When you think of seasonality, you think of influenza, and you think of that seasonal pattern in the colder months and in the winter months in the northern and southern hemisphere, that you would have different transmission patterns. We haven't really seen that with this virus. What we've seen, and to answer the question that you posed to all of us, is what are the main factors driving this? Transmission of the COVID-19 virus, the SARS-CoV-2 virus, is driven by contact patterns. So the nature in which we come together, and this is consistent across the world, cold weather, hot weather, high humidity, low humidity. Now, there are some differences in virus survival in terms of temperature, and humidity will affect the different types of transmission, modes of transmission. But transmission is driven by contact patterns. It's driven by the environment in which people are. So you have more transmission in closed settings where there's poor ventilation, for example, and it's driven by the intensity of exposure. So most transmission that we're seeing is by close contacts, people who spend a lot of time together, family members, for example. There are some outbreaks that are happening in workplaces where people don't have that physical distancing in place. And we know that 10 to 20% of cases are responsible for about 80% of transmission events. That means not everybody transmits. It means that what we're seeing are these clustering and these super spreading events. So if we know where those are, and we know where those are, we can prevent those from happening. And that's what's really driving this. And what you're seeing in these different scenarios that I showed you, those situations, it's driven by the actions put in place by the countries themselves. And so countries, for example, that saw a resurgence lifted a lot of the measures, and in some cases lifted them too soon. And in many countries, we saw over the summer, there was quite a relaxation around individual level measures. There was a lot of movement around, and unfortunately, transmission increased again, which is predictable, in that sense, when you know how it moves. If people are coming in close contact with one another, if they're not wearing masks appropriately, or they're still not doing the physical distancing and wearing the mask, we know that not one measure alone works. It has to be done all together. So the transmission is driven by contact patterns, and that is where we have an advantage over this virus.
Thank you very much, Maria. I think in the interest of time that we will move on to the next question. which I think I can do. Yes, so the next question that we have asking our panel to answer is, what have we learnt during the pandemic? A new virus, unprecedented global situation. What have we learnt to date? And again, I would like to turn first to George to share with us what's been learnt in China to date. So George, back to you.
I think the biggest we learned so far, this is a very special virus. It's covered virus, very clever. And, from the very beginning, we thought this virus might be like avian flu or MERS or Ebola. Obviously, it's not. It's a completely new virus. Common sense doesn't work. Our knowledge doesn't work either. So we have to come back to the science. I mean, this is a completely new virus. We never thought this virus is so particular. I mentioned from the very beginning, even for the origin, from the very beginning, we thought this virus must be zoonotic. Now, I have to give up my own opinion. This virus, from the very beginning, is not zoonotic anymore. The virus already adapted to human beings very well. Why is that? That's a scientific question. This is why the human beings, we have to think about any questions we are encountering in 3 levels: common sense, knowledge, and science. Now, this is a scientific-based question. That's first we learned. Second, and from what we learned, look at my slide. In China, for the Wuhan wave, the first wave, when we first identified the PUE and the virus, we tried very hard and we are so successful. We were so successful for the Wuhan lockdown. We learned with 4 lines, 4 levels, 4 earlys. As you can see, early detection, early reporting, early isolation and quarantine, early treatment, plus the 4 levels for the risk assessment, and also 4 lines, Wuhan and Wuhan's surrounding regions and Beijing capital, because the political will, it was so important. We try to protect the Beijing as a capital and then whole China. This is what we learned. Otherwise, the next slide I show you, if, that's always an if. Let me show you, if we didn't succeed in this, sorry, let me move back. If we are not so successful, we estimated we have so many, cases in Wuhan, in Beijing, and in whole China. So this slide, you already saw this, I don't want to go further. But at the third, what we have learned, it's the methods we can do. This mask wearing, hand washing, social distancing, and ventilation control, even though it's so easy in China, I don't think it was so easy in other countries. So this is some non-pharmacological intervention, but it's very, very important. Though it's important, but it's very difficult to do in any other countries, except in China. What I want to address for the last part, community level control is the key. So this is why we wrote something in the Lancet, active case finding in the community level, and also the facilities and the involvement of the public in the community level, not the central level, are the key for everything. And also, after the Wuhan lockdown, we have, I said already, 6 or 7 waves. There is very, very important for contact tracing in the close, in the community level, and also population level. I'm seeing population level, large-scale screening for the rapid PCR test is very efficient in China. That helps us to trace back all the cases, all the close contacts. This is why we were so successful for the last 6 waves. I hope we will be so successful for the recent sporadic cases in almost 4 provinces. I'm expecting we have some more in other provinces. So that's very important. So that's what I thought, what we learned. First, special virus, and second, community level, strengthening the community level public health measures. Thank you.
Thank you very much indeed, George, for that insightful view. So we'll move again from China back to the European situation. I'd like Andrea to tell us what we've learned over the last 9 to 10 months.
Okay, so there was and still is a lot of talk about waves. Now, what we are seeing is a big wave, but when you look more closely, you see that these big waves are composed of many smaller ones. And that is exactly what Maria also described, that there are these localized clusters that if we would detect very early on, then we could really stop and control at a much lower scale than we have to do now. Now it will take a lot longer time to really bring the case numbers down again. And I think we have seen as during the summer that the virus never goes away. So there is no time ever to let our down and stop applying the measures that George also has outlined. We have, although we have put out a reporting protocol very early in February, we have seen the challenges for our member states to set up robust population-based surveillance to actually detect these events on a systematic basis. And while at first these difficulties were dictated by a lack of material, lack of tests, and so forth, it still is challenging for countries to set up a population-based system for severe cases, but also for milder cases in the public. So that is would be especially important now, where we have to see or monitor not only COVID but also influenza. The second part where we saw really difficulties is the level of preparedness. In February, countries told us, yeah, we have looked at our preparedness, we're prepared. I don't think anybody would say this anymore, that back in for March we were prepared. And that are particular areas of the preparedness that we learned have to be strengthened. That's the hospital preparedness, both in surge capacity for beds and staffing, but also in terms of stockpiling for equipment and materials. But then it's a particular at the local level, the preparedness has to be strengthened, because there is the front line. There it is where the outbreaks can be stamped down on an early basis. We also saw the difficulties in interacting between the sectors. As has been highlighted, this goes far beyond health, and there were sometimes, polarities built between economy and health that are no polarities. They go together, and they have to manage with their different interests. In Europe, it was particularly challenging in the border regions, when countries for the border regions that have a very, very intense exchange on a daily basis implemented measures that prevented this easy movement. The last part that I want to come to, where we saw and where we have learned the importance of, is the community engagement. The fact that we see that people have difficulties now continuing to adhere to these measures that we as public health professionals think they have to be followed all the time, and as Maria said, in a package, they don't see that. And that is, I think, something that we never really engaged in. How how to make sure that the population that has such a crucial part in actually helping to bring this pandemic under control, that they understand why this is necessary, that their freedoms in terms of seeing who they want, going where they want, doing what they want, is restricted for their own protection, but also for the protection of others. I think here we have to not wait for the end of the pandemic, but do some countermeasures already now, because due to the long incubation period, there are no quick fixes, and whatever measures are implemented, the effect is not seen immediately. It takes 2 to 3 weeks until you can assess whether what you have done has an effect, both positive or negative, and that is also something that needs to be conveyed to the population. Thank you.
Thank you very much indeed, Andrea. We'll move straight on now to again get the global perspective from Maria, and then we'll pause to see if there's any comments or questions from you, the audience, we can put to our panelists. So Maria, over to you.
Thank you. So just building on what George and Andrea has said, you know, there's so much that we've learned because this is a brand new virus. You know, we didn't know anything about this, you know, before December. And so in a sense, everything we've learned. And I want to echo what George said, is that the science is driving our understanding. So in a situation, I mean, we know this because we are scientists, we are public health professionals. This isn't, I'm not saying anything new here, but in the complexities of a global response, it's really important that we remind everyone that science drives our work. Science drives our understanding. Science drives our policies that are developed. But of course, it's not only science that is important for the implementation of any policies. So what we have done in terms of outlining what we think, you know, how we are learning about the virus, how it transmits, the disease that it causes, the immune response, the areas in which transmission can be amplified, the roles of different therapeutics. You know, we are really trying to focus on how do we, first of all, prevent infections, and how do we save lives? How do we reduce morbidity and mortality? And so we've outlined 3 major areas where our work is focused and our guidance is focused, and our implementation through our regional offices and our country offices are focused. And you see it on the screen here. So it's all about reducing the opportunities for exposure, the opportunities for infection, even if people are exposed, reducing morbidity and mortality following infection, and reducing transmission overall. And we do that by making sure that we have empowered individuals who are enabled to carry out action. So we have tried to inform individuals about what it is they need to do to go through their day by taking a risk-based approach to minimize the opportunities for them to become exposed and infected, and how each person can play a role in ending this pandemic. If you've ever heard me at any of these press conferences, I say it every time I speak, because so many people feel helpless and so many people feel that we have to wait for a vaccine to bring this under control. The vaccines will be incredibly helpful, but we have within our power right now to bring this under control. But it's incredibly hard. As Andrea has said, it's incredibly hard to be able to do this and to keep up that momentum. But what we've outlined through the evidence that we've gathered is this need for finding the virus, finding cases. So active case finding and cluster investigations, you know, being able to know where the virus is so that we know what public health actions need to be taken. And it's not only, it's not good to just do mass testing. You have to have strategic testing. You have to have testing that has quick turnaround results, and you have to have testing that links to individual actions for that person to know what they need to do to go into clinical care, to receive appropriate clinical care, to go into isolation in their home, to do that safely so that they don't spread the virus to other individuals, to make sure that we have contact tracing and supported quarantine. I think this is really, really critical. Arguably, 2 of the most important things to be able to bring this under control is isolation of cases, and isolation of cases outside of the home, in medical facilities or specialized facilities, so that they can be cared for and that they are away from their loved ones and don't pass it to their loved ones. Or if they're at home, in a way in which they can be separated from their family members so they don't pass it to others, and supported quarantine. You know, we saw this in China in January and in February, and making sure that someone who is a contact of a confirmed case be quarantined, again, supported outside of the home, really breaks those chains of transmission. So what we've outlined is what works. In terms of suppressing transmission, there's a lot that works. Physical distancing works. Hand hygiene, respiratory hygiene, making sure you have clean hands when you put on a mask. Make sure you wear a mask over your nose and your mouth. Wearing a mask under your chin is useless, but wearing a mask over your nose and mouth can serve for source control. It can also be for protection if you're wearing a medical mask. Rapid identification of cases and contact tracing, cluster investigations. You know, this is what works. Some restricted movement helps because it takes the heat out of that transmission. And many countries, we get asked all the time, does WHO support lockdowns? First of all, we don't use the word lockdowns because lockdown means so many different things to so many people. It's a combination of factors that go into locking down. But restricted movement of individuals, staying home if you're unwell, staying home or isolated if you're a case, quarantine if you're a contact, avoiding crowded and enclosed spaces. There have been some stay-at-home orders that have been put in place, but countries that have had to use these so-called lockdown measures really were in a position where they had no choice, and they needed to do something to be able to bring some control back to looking at transmission. We know that in terms of reducing mortality, the first thing that works is preventing infections in the first place, particularly for vulnerable populations. We've seen some devastating effects in long-term living facilities and in older care living homes and prisons, which is tragic because if the virus enters those facilities, it could have high morbidity and really high mortality tragically. And if we could prevent that from happening, we could reduce mortality. We know early actions, and this links to George's slide, early actions, early clinical care, early assessment at the first point of entry, lowering those physical and financial barriers for people to access health services. You know, looking at checking someone's oxygen saturation can help very quickly determine if they need oxygen, if they need mechanical ventilation. And we have the use of dexamethasone, a widely available, inexpensive drug that saves lives for people who are severe and critical disease. And of course, not only focusing on COVID, but making sure we have essential medical services up and running so that everyone gets the care that they need for everything that they need. And then lastly, to comment on what Andrea was saying, we need empowered communities. There's no question. And that was one of the things I was most struck by my mission to China in February. When we met with many different individuals, everyone that we met with knew exactly what they needed to do, knew exactly what their role was in bringing this virus under control. And we need everyone to understand what it is they can do. We need to listen and understand what are the barriers for carrying out certain types of actions and behaviors, and try to support communities, families, communities, regions to be able to carry out these actions. It is not enough to say, please do this or do this. We need to really enable countries to stay home if we ask them to stay home, so that they know that they will be fed, know that they will not lose their job. And it's really important that we engage and discuss and listen and try to find the right measures going forward, because we're in this for the long haul, unfortunately. And we need to make sure that the populations understand what it is and that they need to do, and how each of their decisions can contribute to bringing this pandemic under control. I'll stop there.
Thank you very much. I would like to thank to all the speakers for this addressing this very important question, what we already know. And I must say I'm really struck by how close you are in what you say about the situation and the role of actually the community to use the science that has been already you know, the outputs of the science. We do have a question from the audience to Professor Gao. China managed to control the first surge of the epidemic very rapidly, and during many months, the levels of the local transmission stayed very low, but over the past few weeks, a few locally transmitted cases have been reported in at least 3 different areas. And in spite of the strict restriction measures and border control measures, and the question is, what do you think drove this resurgence?
Magdalena,
Yeah.
can you see the question again?
Yes, the question is, what do you think drove the resurgence of cases over the last few weeks in several areas in China?
Oh, the size, I didn't understand well. So the size, I mean, what?
That you see again the cases in several areas.
Yeah.
And what do you think drove this? Given that you have very strict
resources or something like that, drive the resources or something like that, right? Well, you know, in China, I didn't have enough time to explain why I think we have 7 waves. When we see waves, that means every wave you have the virus cleaned. So that's very important when you see the waves. So that we have so many sporadic cases, for the last 3 weeks. Because we always can trace back what kind of virus we had. Because in China, after Wuhan initial outbreak, the virus was cleaned. We don't have any, Wuhan-like virus anymore, because that's the virus. It's different in terms of the evolution of phylogenetic analysis. For example, for the last 3 weeks, the first one is in Kerkhove, Xinjiang province. Xinjiang Autonomous Region. So this virus looks like from a sequencing, because we can also do the next generation sequencing. The sequencing tells us it is from the land transportation, maybe from somewhere in the neighbor of Xinjiang Autonomous Region. And also we found in Tianjin and Shanghai cases, the viruses, we did the sequencing, the virus from some virus in some areas like India and America. So it's so easy for us to trace back what we thought most likely they are from the coverage of some foods, especially the seafood. So obviously the package materials from those packages. So the conclusion at the moment in China, it's not the local transmission is human to human. But anything with the initial one, the patient zero, is from the materials to human. Thank you.
Okay, thank you very much. There is another question, but I think it can go into the panel discussion afterwards. And in the interest of time, we will now go to question 3. What are the main trends that will shape the pandemic during the next year? And what do you think are the key messages for the public health community? And let me again ask first George to show us the Chinese perspective.
Okay, for the question 3, the message I will give 3 messages. First one, do not give up. Go back to the community. This is what we have done. This is what I saw a lot of countries, they give up. They did give up for the community level control. They didn't want to trace back to the patient zero. So how and what we have done is community level. So go back to the community. And second, try to understand where and how the science will drive us. Like Maria said, science drive is the key. So foresee the future. So we have to rely on what we will know from the science. And the last message is vaccines. When you see the vaccine will shape the pandemic next year. So we have to work very hard. I'll give you a very brief outline what we have the candidate vaccines globally. And also I give you 2 messages, 2 examples of Chinese the vaccine developed in China. The first one, adenovirus based. And the second one is inactivated vaccine. Why in China we could do an inactivated vaccine? Because my organization, China CDC, we lent our BSL-3 lab to the company, two companies. One is they call the Sinovac. The other one is CNBG. So they use our BSL-3 lab to globalize to develop the vaccines. So that's very, very important. You need an emergent use of the BSL-3 lab. This is why we got the area we can get the inactive vaccine. So I will stop here with those three big messages. Thank you.
Thank you very much. So I would like to ask now Andrea to tell us about the same question from the European perspective.
Yeah, thank you. Now, what will happen next year, I don't share what I have presented here. I don't think you need a crystal ball. And I also think some predictions are, of course, difficult depending on how far in the future you want to go. But some things you can already foresee, although I think the virus has surprised us during this year many times. So I don't know what it has in store for us. But from what we have seen this year, I believe we have to look into preventing and learning the lessons now from this resurgence and trying to prevent or future waves, or at least to keep them low. Now, the first opportunity is Christmas and New Year. We have made some forecast because we are seeing now the measures that in Europe have been implemented are showing some results. So the curve is tipping and going down. And of course, now everybody hopes that for Christmas, the measures that have been put in place can be lifted. Now, our forecast shows if this is done before Christmas, now, basically, beginning of December, then we will have a further resurgence already before Christmas. If we do it later in December, then we may have an increase in January, February. So there is no way out of that, that we have to keep a certain level of the measures in place. Now, that's the first thing that we have to now really discuss also with the experts in the member states, and the message that we have to convey to the decision makers. The second part is exactly as George said. I think we had heard some very encouraging news regarding vaccine candidates that pass now through the trials. So we may have next year one or more even vaccines available, but we have to get ready for this. We have to prepare now in terms of putting out platforms that can monitor the safety and effectiveness of these vaccines, because from all the polls we know that safety and the effectiveness of these vaccines are the main concerns of people having some doubts of getting vaccinated. So we have to ensure that we can monitor this from the beginning in a transparent way, so that we can give reassurance or follow up on things that happen. The second part is the communication around this. The third part, preparation, goes to the deployment planning, because some of these vaccines have special requirements in terms of storage that have none of the vaccines that we have right now requires. Some of the vaccines require that you have two doses, so you have to have a good recall system to ensure that everybody actually gets the 2 doses. You need the materials for mass vaccinations and the staffing. The last part here in the preparation is to determine who gets the vaccine shots first, because at the beginning, everybody is aware that there will be a limited availability of doses, and only over time this can be increased, and the range of groups in the population can be enlarged. So these agreements have to be done now, and from the European Commission has given out already a communication where the groups were listed: healthcare workers, medically vulnerable people, elderly, essential workers, and those that cannot do physical distancing. But the exact priorities in these groups still has. And lastly, I think we have to begin now to analyze the gaps in our response and fortify the preparedness, and not to wait until the end of the pandemic. Part of this is also making use of the new developments. We have introduced contract tracing apps. George has mentioned the rapid tests, and we have to see really how we can harness these potentials. I stop here.
So we could now move on to Maria to address that same question. What does the future hold, Maria?
Thanks. Easy question for all three of us. What does the future hold? I mean, one first point is that the future is completely in our hands. It is completely dependent on what we do, and it depends on what we do every day. Our actions matter. Actions of individual, actions of families, actions of leaders, they matter. And these actions have consequences. So if we do the right things, if we put in the measures that are in place that are really hard to do, but using the tools that we have now, that will change the course of this pandemic. And getting ready for a vaccine, absolutely wholeheartedly, is what the world is doing. We have several areas of focus critical areas of focus that we're looking on now. And what we need to be able to change the course of this pandemic is really strong collective global action. We need cohesive national leadership and implementation. We need coordinated regional and global implementation of these strategies. I mean, especially in Europe. Europe is a great example. The size of Europe and the borders and the way in which people move, to have a coordinated approach across the countries is really, really critical to make sure that there's a collective action that is really driving transmission down and keeping it down. And one of the things, if I could emphasize the most, is to scale up now. Even countries that have brought transmission under control, and I'm talking across the world, countries that are in an intense transmission, scale up now. Scale up your public health infrastructure, your community health workers, your individuals who could do contact tracing and testing and active case finding. Scale up your medical workforce so that you have trained, rested medical staff that can care for patients, not only for COVID, but for all other diseases. Make sure that you scale up your beds, hospital beds, your ICU beds. This will not only benefit COVID, but it will benefit other infectious diseases, other chronic diseases that are affecting all of the countries. Scale up your supplies. Do this now. Really can't emphasize this enough. Now is not the time. Andrea has said this. Now is not the time. There is no time to lose. There is absolutely no time to lose. And we have to continue to scale up through this, because that will make us prepared better as we deal with the next one, because unfortunately there will be a next one. We need to continue to focus on the reduction and the controlling efforts for transmission and to prevent these amplification events. We can do this because we know where these amplification events are happening, and making sure that you have the individuals to carry out those cluster investigations. In many countries, they're not able to do contact tracing effectively, but you can do cluster investigations. We can save lives. We can save as many lives as we can. There's been a tragic loss of life in this pandemic, and it doesn't need to continue. I mean, there will be people that we can prevent from getting infected. There are people that we can prevent from dying. And everyone in the entire world is getting ready for the rollout of vaccines, but not only vaccines, vaccination. And Andrea has outlined this beautifully, all of the different elements that are absolutely necessary to get vaccines underway. And we are working through the ACT Accelerator, which is this incredible collaboration across so many different organizations, which have all of the principles and all of these agencies working on integrated work plans and budgets to be able to accelerate and deliver new diagnostics, new therapeutics, and the vaccines that are coming online. And it is incredibly promising. I feel that there's a new sense of hope that people have, hearing some of the results of these phase 3 trials. I have been accused of being overly hopeful, and I am happy to be called overly hopeful because, quite frankly, I've been called much worse in this pandemic, but being called hopeful is one that I wear proud, because there is a lot that we can be hopeful for. But I want people to think that they are the hope too. Like, each of you are the hope in getting us through this. I'm a bit of a cheerleader at the moment, but I really feel that people need to understand that there's a lot that we can do now to save lives. So we will continue to prepare, to empower, to respond, to support all of our member states, to support everyone everywhere, to carry out these individual level measures, the community level measures, making sure that governments are able to implement these strong plans, to be able to use the new tools that come online. The antigen-based tests are really exciting. The ones that have been validated and evaluated, can really alleviate some of the pressure on the PCR systems. And there will be more tests that will come online. So we need to ensure that countries are able to continue this work. But really, don't give up. I agree. Do not give up. Scale up and use the tools that we have right now to save as many lives as we possibly can. One thing we haven't mentioned, I think, at all, maybe I've missed it, but one of the things we are really, really worried about is long COVID and this idea of these long-term effects. And so for anyone that says that this isn't a big deal or this is just like flu, this is not flu. And we knew this from the start. But these long-term effects are really worrying. And we don't know what the population is going to look like in the future, having all of these long-term effects. So as many infections that we can prevent, we must. And I will stop there.
Thank you very much, Maria. Thank you to all our speakers for really interesting, fascinating insights into where we've come from, where we're going. There've been some very interesting questions come through the online system, and there are a couple of them which I think before we move to a more general discussion, because I think these fit with the last couple of presentations. A couple of questions which I think are related. One of them was, do we think that those countries that have had to particularly live through SARS-1 and MERS and had to develop response and plans to deal with those, do we feel that actually they have been any better able to respond to COVID? But similarly, a similar question is about the do you think that pandemic flu preparedness plans would have helped with COVID-19 if fully implemented? And I guess behind those two questions is, do we need a new plan for every time a new infection emerges, or are our existing plans actually effective and it's a question of implementation? A difficult question, and I just wonder, perhaps I could ask Andrea if she'd like to answer first.
As to the first, I think is something that we would have to analyze, really see those countries that were affected in the first SARS, whether they have better responded, and maybe Maria has the better overview, because none of these countries is actually in Europe, and because we got away very lightly with both of these. So as for the second question, I personally believe there is a general general level of preparedness that will allow to deal with a variety of different emergencies. However, there is, of course, always the need to adapt to the specific circumstances. And yes, I think the plans may not have been actioned or actionable to the degree we would have hoped. And I have outlined before already some specific areas where I believe we need to pay more attention to. Many of the preparedness plans have been looking most at the national level preparedness and less trickling down the interoperability between neighboring countries, and in then particular also the hospital preparedness, not only for the big university hospitals, but also for the ones in the periphery, that in cases like this are really the first place where cases will really land on. And then it goes then down to the practices and the local health centers. So I think, yeah, there are some elements that we can discuss to fortify that may help us in general. But I also believe that depending on the specific properties of the pathogen causing the emergency, there will have to be adaptations, but they have to be done at a higher level than we have been, in my view.
Thank you very much, Andrea. So, Maria, MERS, SARS-1, if I can call it that, do you think that experience of dealing with that has equipped us better?
I think absolutely. I think countries that have had to deal with diseases like SARS, like MERS, like avian influenza, you know, and don't forget all of the countries across Africa, the hugely diverse, incredible countries across Africa that have had experience with infectious diseases, high threat infectious diseases like Ebola and monkeypox and cholera, and all of the countries that have the experience of using public health tools and building up their public health infrastructure. You hear us talk a lot about this. And quite frankly, have had the trauma of dealing with an event like, you know, I think a lot about MERS in Korea, in the Republic of Korea in 2015. That was a traumatic experience for Korea. And they completely changed their entire system in terms of workforce, in terms of law, to be able to deal with infectious agents. And when they were dealing with a really large outbreak, we were also, I was in China with Professor J.K. Lee at the time. They were speaking to the leadership in Korea and saying, this is not flu. We are seeing it being controlled in China, and you can do this in Korea. And they turned it around. We've seen this in so many countries. Look at across the Mekong Delta region. Look across countries in Africa that have really utilized the systems they have in place. Countries in Nigeria, the head of Nigeria CDC, Dr. Chikwe, would say, we may not have, you know, testing where we can test everybody across the country, but we know how to do contact tracing. You know, we use our supplies strategically and resourcefully. But I think the trauma that people have had with other outbreaks have really propelled them to take really quick, decisive, comprehensive action. I am hopeful that through this unfortunate situation that the world has been in, that the trauma that most countries have had to deal with will propel them to really take action. We cannot be in a situation like this again. We should not be in a situation like this. There's no reason where we need to be. So I am very hopeful that countries will be able to use this experience to really drive preparedness further. It will take a lot of work.
Thank you, Maria, and perhaps George. And George, I understand you will need to unmute yourself. George, I just wondered. I mean, I think that the world was impressed with the speed with which China managed to suppress that initial large wave. To what extent was that simply a case of implementing plans that you might have had for influenza, or did you actually have to implement new measures for this new virus?
I think, Mike, that's a very good question. Combine the two questions you asked earlier with Maria and Andrea's answer. I think, we think, the human beings, we think we learn lessons, we learn experience, we could do something. So this particular virus tells us, you cannot rely on whatever you have done, whatever you learned. So obviously, this virus is particular. We tried very hard. We thought from the very beginning, maybe this virus have an intermediate host. It could be like avian flu or MERS. So by that, it's not. In China, for the first wave in Wuhan, we implemented the method, lockdown method, like what we did for the SARS. And in UK, they proposed for herd immunity. So, finally, it didn't work, herd immunity. And also for China's lockdown, it works for Wuhan. I don't think it will work for the rest of the time for the next year or even now, because we have so many imported cases. It becomes a pandemic. If the virus in somewhere outside of China, I don't think China itself, we can really get rid of this virus. And more importantly, the way we are dealing with the H5N1, H7N9, the MERS, it works. And we try to copy the same method. It doesn't work this time. So because the conclusion is, it is a brand new virus. That is a brand new, something brand new. So it's, it's very, very hard. So we have to, by learning from this pandemic, in the future, we have to think about from the very beginning, is this particular virus special? Is this virus has its own identity that is different from any other known viruses? So I think this is the question, and this is something we have to bear in mind for the future. I stop here. Thank you, Mike.
Thank you very much, George. I'm going to hand back to Magda to start off the closing session, which is a panel discussion or debate around a few questions we thought of beforehand. And we've had an interesting question from the audience that, Magda, you might like to lead off with in terms of questions about if we were to see another new pathogen emerge. Magda, over to you.
Thank you, Mike. Yes, so the last part of our session is the panel debate on the challenges around communication and interplay between politics and the science. And one of the issues is restrictions about cross-border movements. And the question from the audience was whether, if by any chance a new pathogen emerges, whether we could hope that by closing down this area or restricting any movement around this area where this pathogen emerged, whether this could be efficient strategy to control this pathogen to actually spread around the world. And perhaps I could ask Maria to take this first.
Thanks for the question. I was actually hoping you'd start with George because he has direct experience with this. I mean, I think that the idea of movement restriction, there's a lot of discussion around this. There's a lot of debate around this and what could have been done when in terms of travel and trade. And the rules of the international health regulations in terms of what WHO is able to do in terms of putting out recommendations for travel and trade. In terms of viruses themselves, I mean, by the time a virus is detected, and in the sense of the initial cluster of this, or an initial cluster anywhere, it doesn't have to be SARS-CoV-2, it can be an initial cluster anyway. By the time that is detected and investigations are underway, people can move when they don't have symptoms. People can move when they are, and in this case, in this particular virus, people appear to be most infectious at or around the time they develop symptoms, which includes before they develop symptoms, which makes it harder, not impossible to control, but a lot harder which is very, very different than SARS and MERS, where people are most infectious when they're severe and when they're in hospital. And so adding in restrictions of movement or travel and trade restrictions is something that needs to be weighed very carefully because it has massive economic implications. I think it's without question that some of the stay-at-home orders, when they have been put in place, if they were put in place at a certain time, did have an effect on reducing transmission. We're still seeing that. But I think what we need to get to is the balance. Like, what is the right balance of restricted either individual movement or population level movement while keeping economies open? You know, you've heard today, there is no dichotomy between public health and economy. It has to be both. But what is the balance that we need to get to where we can keep the transmission low and we can keep economies open? But I think there will be a lot of discussion. What I would like to see is much more analysis using the situation now to look at what could have been done, what should have been done, was there a possibility, and in each location to see what could have been possible.
Yes, that's incredibly important to learn from what we actually been through during this pandemic. So could I actually ask then, George, as Maria said, you have the direct experience with dealing with this event initially in China. Could you comment whether, do you think it's possible to implement such restrictions in movement as to totally eliminate the risk of spread?
I think that's a very, very good question. I was asked, you know, for almost a year, is it possible we could do something better? Is it possible we get rid of this pandemic? That's always a good question. So I already commented from the very beginning. So the virus and the human beings, like Tom and Jerry in Disneyland, it's very hard. You know, we'll have another one, new one, might be very similar situation will repeat. You know, look at what happened in China. Why we proposed for the lockdown. You know, only within 20 days, we realized that could be a serious problem. We locked down Wuhan. We have a very strong political will in China. So the leadership has strong leadership. Oh, let's lock down the whole city. Can you imagine? By then, a few hundred cases, you made this such a disease with 11 million people there. It's a big city, and it's about the time for the Chinese New Year. You know, get together, it's always there. It's very, very hard. By introducing this lockdown measure, we thought we might be able to stop the pandemic. Maybe at the very beginning, maybe the epidemic. Then later on, pandemic. Then we found, you know, it doesn't work. The pandemic is here. It's a real pandemic. So in my opinion, you know, it's very hard. You know, we think lockdowning of the Wuhan would bring the benefit of the saving the world. So it looks like, you know, it didn't work. So in my opinion, the audience asked if we have a new pathogen, if we try to block down the original place where the emerging virus, you know, came, I think it'll be very hard. If you have a virus like this COVID-19 virus, it'll be very, very hard because the characteristics of this particular virus. You know, looking back, if we thought like the H7N9, H5N1, or Ebola, or MERS, any, you know, new viruses, we think the virus needs some time to accumulate some mutations to adapt to human beings. So now we know it's not. You know, this is why the answer is very hard. Thank you. I stop here.
Yes, thank you. Yes, it seems such a huge challenge with a virus so well adapted to the human population as this one. I would like to ask also Andrea to comment, especially from a European perspective, that the restriction of movements is really difficult. What do you think? Would that be possible if it happened in Europe?
Well, I think we have, of course, this discussion also in Europe in terms of the measures with travelers and restrictions to cross-border movements. And what you have to keep in mind is two things. What is the purpose and what is the feasibility? And the purpose usually is said, well, we don't want to have any infections imported into the country. One purpose could also be to make the travel itself safer. And then there's the feasibility. And in terms of the feasibility, as Maria has pointed out, those countries with relatively few entry points like islands have, of course, their higher feasibility to do checks at the border than most countries in Europe that have a multitude of land crossings in addition to the airports. So the feasibility is one question, but then it's also the purpose of preventing importation. And I think that in our view really depends on the state of the epidemic that you're in. When you have already widespread community transmission in your country, as most of the European countries currently have, we do not see that border or travel measures are effective means of controlling this pandemic in the country. That may change in the moment where you have a situation where the case numbers are very, very low. Then, of course, it may matter whether you have cases imported or not. So I think there are other considerations that need to be put in place. And right now, in this widespread community transmission that we widely have, travel measures or measures with travelers would or will do actually divert resources that could be also used within the countries for controlling the pandemic in the countries. So at the current stage in the situation that most of the EU countries are in, from our point of view, this would not be an effective and efficient measure.
Thank you, Andrea. So I think we need to move on to the next question, which is around what do we know about the effectiveness of interventions? Maria made the comment that we must use science. We must use science. We must look to the science to help us in making decisions. But one of the questions is, what do we know about the effectiveness of measures? Because often measures are being applied in bundles. So, Maria, you particularly spoke about masks in your presentation, and that's been a fairly intense topic of discussion in some parts of the world, and Europe is one of those areas. And I just wondered whether you feel that we have robust evidence on the relative value of different intervention measures, or whether really at the moment we're still at a stage where we need to apply measures in bundles.
So it's a great question. We still need to apply measures in bundles. What we know is that no one measure alone works. I should rephrase. No one measure alone is enough. So masks is a great example. So masks are part of the package, but they don't work alone. You need to make sure that people are still using hand hygiene and make sure that you don't inoculate yourself when you put your mask on and you take your mask off. We know that there's an importance of hand hygiene, cleaning your hands. It may not be the major driver of transmission in terms of fomites, but it's a contributor. And if you have contaminated hands and you're contaminating your mask or whatnot and you touch your eyes, that's really important. What we have seen, I think, in a number of countries tends to be an over-reliance on one measure, whether it's testing. We must do testing. You must do mass testing. Testing is critical, so you know where the virus is, but testing has to be used with public health action in terms of knowing what to do with the patient or the individual and what they need to do next. Masks are really important, but they can't be used only and then we ignore physical distancing, or we allow ourselves to congregate and be close with one another in poorly ventilated settings, for example. All of it has to be applied. And I think what we need and what we're seeing is we're seeing behaviors change and modify. In most of the world, these are slight modifications that each of us need to make. These are slight sacrifices that each of us need to make to contribute to reducing the spread. And I think that that's a reasonable ask that we have right now. But in other parts of the world, they're quite drastic. I mean, to tell someone to stay home who is a day wager, who relies on that income every day to be able to not only feed themselves, but feed their families, if they are not supported in being able to carry that out, it is not something that can be adhered to. And I think we need to find ways to use the funding and the packages, the financial packages, to also be able to support small businesses, to be able to support, individuals that have to stay home, to make sure that the measures that are put in place really can be applied more universally. We've seen incredible inequities, devastating inequities that existed before this pandemic really being exacerbated by the pandemic. And there's a lot of lessons to be learned here. This double injustice that we are seeing, but there's a lot to be learned, and we really can start to apply those now, not for the next pandemic, now. And we are seeing countries use this approach, use the lessons learned now to continue to have a better response in this pandemic. We need to make sure that the lessons learned that everyone talks about is not just for the next one, it's for now.
I'm aware that we're running out of time. So Magna, do you want to pick up on the next question, which is response fatigue and I can't.
Yes.
Yeah.
Yes, there's a number of issues regarding the response fatigue, and one of them is effective communication and how to deal with this. So I would like to ask maybe just for brief comments about this particular issue. How do we effectively communicate so to avoid and engage the community, in fact, as to avoid the danger of the response fatigue? And maybe I will pass to Andrea first.
Yeah, thank you. I think that is also a major difference that we're seeing compared to the spring, where the majority of the population actually was very willing to comply with the measures. Now it is more difficult. And I believe that all the tools from community engagement, science again, have to be mobilized. So basically not talking to communities, but talking with communities. Maybe also not saying, well, you mustn't do that, but you have to do things in a different way because it has the same result, but it has a completely different tone, and engage the communities also in the ways how this the measures are shaped in certain communities. I think it has to be recognized that everybody has been making sacrifices, and explained why it is necessary to continue to do so in a certain way. I also believe that there is still room for further research in terms of, because as Maria said, now the measures have been done in bundles, but there are maybe also still facts to be teased out. For instance, what are the places that are really propelling the transmission, and they may depend on different age groups, maybe different places. And the last thing that has to be conveyed, that we are talking about a reduction. I think we the aim of saying, well, we reduced the transmission to zero, or the transmission risk to zero, I think in the current situation is a delusion. So we have to aim at a reduction as far as possible. And
Andrea, I think we're going to have to, unfortunately, draw things to a close. I think we could have gone on speaking for a lot longer of this, but there will be opportunities through the rest of the day. Please join the other 5 of the day and this afternoon's plenary. But could I just close by thanking our speakers for excellent presentations and for answering the questions. So George and Andrea and Maria, really big thanks to you. And also just to a couple of points that I picked up from this, I think key messages that came through to me is in such situations, you need to act fast, you need to engage the community, don't over focus on single measures to control or prevent, make use of the science. There's a need for clear and strong leadership. Border controls unlikely to ever be the total solution to dealing with a major emerging infection. And last but not least, we need to learn and we need to apply those lessons in a sustainable way as we move into the future. So with that, let me thank the speakers, Magda, my co-chair, and I think we now pass back to Martin in the studio, as they say.
Thank you very much, Mike and Magdalena, for a fascinating panel. Thank you also to our speakers. I've personally learned a lot. It was a really interesting panel. Now, ladies and gentlemen, that brings to an end our opening session, and the next events that we have coming up are the fireside panels, where we will be exploring further this theme of COVID-19. At 1300, we have COVID-19 serology and prevalence. Then at 1410, we have a fireside panel on COVID-19 response. And then at 1520, we have a fireside panel on COVID-19 surveillance. Once again, please do go on to the abstract presentations and look at the pre-recorded presentations so that when you come to the fireside panel, you've already seen those presentations and are ready to engage in the debate. Final message, just before we go into the break. One of the hidden gems of escaide 2020 are actually the posters. And if you've not visited the posters yet, I would strongly recommend you do. There's a huge array of different scientific posters, very interesting topics. Do just click on that. And most importantly, if you're interested in one of those posters, go to the poster forum. It's the button next to posters on the navigational chart. And there you will find the authors of the posters are waiting, and you can send them messages and you can ask them questions. And you say, what on earth were you doing when you put this on your poster? Or how does that link with that? Really interested, like to learn more information. So do go and visit those poster forums. As I said, it's one of the hidden gems of this forum over these 4 days. So do take the time, click on those, go and have a visit, and send your comments through to the author of those posters. That's it from us now. Please do go and have a look at the abstract pitches, and we'll see you back here at 1300. Thank you very much.